Fine.
I'm just going to pause.
I feel like I'm the only one in the group who's not intimately aware of all the things you do, but you gathered a crowd in a hurry. And it sounds like you and I have had a lot of overlap in our training. I was at WashU for my peripheral nerve, and then went over to spend time with Dr. Chuang and at Chang Gung for a couple of weeks, and came from. So it's great to finally, at least virtually, meet.
Yes.
Lots of great things about your work. So I'm going to go ahead and turn the rest of the hour over to you. And if you don't mind, sometimes we love to interrupt and ask questions. Is that okay as you go?
That's fine. Just make sure I'm still connected. It's happened before. I present for like 30 minutes and I realized I was offline. So
absolutely. We'll ring you if something like that happens.
Yeah.
Perfect. Well, we got your talk up here. You can go ahead and get started.
All right. Thank you so much. I just finished the surgery just now, so I might be a little bit hazy, but my name is Johnny Liu. Just call me Johnny, please do. I work at Chang Gung Memorial Hospital. Definitely, it's an honor today, and it's one of the instances where it shows that Instagram works. That's how we got started with the contact. So definitely, social media has its there's some disadvantages, but definitely this was a major big advantage for me. So I'm very, very honored to present to you guys today. My topic is going to be focused on vascularized ulnar nerve graft in panbrachial plexus palsy. And definitely, first of all, I just want to start off by saying, yeah, it is true. Like, my teacher is David Tron. I've worked with him for many, many years, ever since I was a resident. Ever since after I finished my I didn't really finish, but I did a lot of clinical training with them. I decided to pursue a research fellowship, and that's where I went to St. Louis in 2017, and then spent 2.5 years there. And mainly my mentor is Susan McKinnon, who's perhaps, I would say, probably the world's most famous pioneer in nerve surgery, and she's done so much for and inspired so many of us. But she was the one that introduced me actually to Allison Snyder Warwick, who does a lot of work on neuromuscular junction. I won't get into that today, but it's something that I'm very passionately believing in, since muscle has always been the problem and kind of something that's kind of been like the blind spot in peripheral nerve surgery. But that's kind of my background. This is a great picture I had at ASPN with two of my mentors, which I really, really cherish this moment, just to have them together. This was a lab that I worked with, mainly with Allison, but I also worked with Matt Wood and Dan in the peripheral nerve lab and did some research there, but I think mainly was just to learn from them. I have been in Boston for, I think, 5 times or more. Okay. Once when I was a clerk, once when I was a resident, and I came for several meetings and conferences. I love Boston. I think Boston is one of the best cities in the whole world. So there is a link between St. Louis and Boston, not just the WashU link and, me and Dr. Brown's link, but there's this thing called, Stanley Cup. And I hope people don't mind, and I'm not trying to get off on a bad start, but yeah, that was a very interesting link and a happy ending for me. So I have no conflicts of interest to disclose. Now get right to my topic, acute panbrachial plexus. Definitely our strategy is that we explore always all the brachial plexus, even if it's a possible total root avulsion. So our donor nerves that we plan, it's always decided intraoperatively after the exploration. And that's important because it depends on the route that we find. So definitely the donor nerves, we don't go ahead and automatically do spinal accessory, do suprascapular, the double fascicular, or something like that. We don't do that. We plan during the surgery, but after confirmation of our initial planning. So it's all about location, and I'll get into that later on. Recipient nerves, for panplexus, the priority is always the elbow, and elbow flexion is definitely the one I'm talking about. Then comes shoulder, but hand is something that's always been neglected. But definitely in David's hands, I think he definitely respects it, and he puts a lot of effort in that. And that's why we did the vascularized ulnar nerve graft. And for us, the functioning free muscle is always a backup. It's never really a primary option. We don't do it acutely during the first surgery. I work with David and Tommy Chang, and that's my name, Johnny. So first off, one of my topics is going to focus on panbrachial plexus palsy with available roots. And so it's very important that, David likes to use the term spinal nerve rather than roots. And this has to do with his belief that the postganglionic distance of the postganglionic segment is just too short. So we should always talk about the spinal nerve, in which that is the nerve that we really explore and use. For all spinal nerves, we look at C5, C6, it's important to determine if it's a usable root or not. And so if it's avulsed, basically practically means it's not a usable stump. But if it's a ruptured stump, then it's usable and something that you can use. Something that has been kind of reestablished our exploration and our technique for the past 10, I would say 10 years, has been the use of MRI. And our radiologist, the senior author here, Professor Kim Yao, devised a strategy where he can look into the ventral and dorsal rootlets, and using multiple types of views, but mainly the Fiesta view is the one that he really uses. And he does a grading preoperatively that allows us to have a kind of an impression whether or not it's going to be a good root or not. So if he tells us that it's a level 2 rupture, as shown here, there's a very high compatibility. And when you cut the nerve, you practically see mushrooming, or you practically see a good root. If he tells us that it's avulsed or nearly just a one rootlet present, more often than not, we don't see a good cut surface. Next comes the recipients. And, after you decide, in these cases where you have available roots, you also have to decide what you want to coapt to. And in the panplexus, as mentioned before, muscocutaneous and median nerve, and also the shoulder abductors are the ones that we focus on. But you can, it depends on whether you want to coapt it proximally or distally. And I think there's two fields or two different opposing views on this. In the paper by Dr. Sokolovsky, this was published in 2021, but actually there's an earlier paper in which this team, this unit talked about coapting, whether or not it's better to coapt distally or proximally. And in their view, they believe that if you coapt more closer to the target muscle, but at the same time you have a longer nerve graft, you get better results. This is with Dr. Bertelli's work, where in 2010 he talked about using in panbrachial plexus, panplexus cases, if you have a C5 and you coapt to the muscocutaneous nerve, I'm going to minimize this, sorry. And you coapt to the muscocutaneous nerve, even when it's the length is 17.4, you can reach more than 80% of M3 or M4 elbow flexion. And I have no criticism of this. Obviously, some people do have kind of hesitation when seeing such a long nerve graft. But I do believe when you coapt to the muscocutaneous, it is a better outcome compared to the anterior division because your axons don't disperse. But with longer nerve graft comes, poor outcomes. And mainly, I think the work by Susan and Matt Wood looks at the senescence of the nerve grafts. And this was an experimental study, but I do believe in this study where there is a senescence of the Schwann cells inside the nerve graft that really practically hinders the nerve regeneration. So you come up with this dilemma, do you coapt very distally, closer to the target, which may give you a stronger power, but then a longer graft means longer regeneration time and more unpredictability. If you coapt proximally, of course, you have a shorter nerve graft, which is really good, means that it's more reliable. But then you have the dispersion of axons and uncertain recipient status. You might even have a double crush injury or a multiple site of injury along that anterior division to the muscocutaneous nerve. So for us, that is how we came about the vascularized ulnar nerve graft. And in order for the vascularized ulnar nerve graft to really work, the priority or the indication has to be that the C8T1 has to be avulsed. There's no hints of any sign of recovery of the finger flexions or the wrist flexors. But with the vascularized ulnar nerve graft, there are multiple sites of perfusion, and mainly that comes from It's also always been described by Dr. Gu, from China, that the superior ulnar collateral artery is the main artery that you can use when you transfer it as a pedicle on a pedicle vascularized on a nerve graft. But for us, for Plexus, our belief is that if you want to get a good outcome, it is better to reach that more distal target, either the median nerve or the muscocutaneous nerve infraclavicularly through the use of vascularized nerve graft. But if it's an incomplete brachial plexus, if it's for shoulder, if it's for elbow, a sternal nerve graft is enough for incomplete brachial plexus. So back to this vascularity of the nerve graft, for any types of nerve graft, whether it's non-vascularized or whether it's a sternal nerve graft or a ulnar nerve graft, there's practically three sources of perfusion. One comes from the accompanying nutrient vessel, which directly nourishes the nerve. One comes from the longitudinal inoculation from the proximal nerve stump. And then one comes from the centripetal revascularization, which practically means from the wound bed. And for a sternal nerve graft, I think mainly it comes from 2 and 3. There is no accompanying nutrient vessel unless you vascularize it. But for a vascularized nerve graft, I think the main advantage is that it allows trunk grafting. It allows you to have a longer distance of that nerve graft and allows you to tolerate that environment. Some have claimed that it's good. You may use a vascularized nerve graft in a subacute setting, but I would not do so. If it's a Plexus, do your best to try and operate. If you're reaching that 6-month stage, do it early rather than wait longer. So our strategy when we do use this vascularized ulnar nerve graft, if you do have an intact nerve or if you have a suspected like a ruptured spinal nerve stump that you can use, we prefer to use this vascularized ulnar nerve graft and hook it up to the muscocutaneous. And the distance usually goes about 15 centimeters. For intercostal nerve to the muscocutaneous nerve, I would say that that is more of our second option. For finger flexion and to restore sensation, we use that same stump, but we hook it up as another target to the median nerve. So in a way, there is a co-contraction that occurs between the muscocutaneous and the median nerve. But that co-contraction can actually benefit the patient a lot. And we always use the functioning free muscle as a backup, unless it's a chronic case. So for a vascularized nerve graft, there's no doubt that the time to revascularization is shorter than you would say an allograft, but the complexity and the anastomosis does make people hesitate about using this vascularized autograft. And so Bertelli has definitely presented on this, trying to graft from the C5 to the muscocutaneous nerve using the pedicle vascularized ulnar nerve graft. And in that study, in which he used the superior ulnar collateral artery, and in the results that he showed, none of them were greater than 2 for either elbow flexion or wrist extension. And they believe that it's because of the unfavorable internal morphology of the trunk graft. I'm not going to say just but we don't necessarily believe that. I think the primary concern, the problem still comes from that it's used as a pedicle vascularized ulnar nerve graft. When you use a superior ulnar collateral, which is more superior, more proximal, there's a harder time for that to reach the most distal end, which is actually what you use to flip and hook up to the contralateral C7 or the C5. So that is actually where the circulation is the poorest. And if you flip it, as with any propeller flaps, there's the possibility, if you flip it 180 degrees, that you may have slight problems with perfusion at the most distal end. But the ulnar artery, which is located right in the middle, just in the middle of this ulnar nerve graft, it has huge vessels. I don't even need to say this. Anyone that's done ER and anyone that's worked with these has seen the size of these vessels as compared to the superior ulnar collateral. And with the ulnar artery and the ulnar vein, you're able to harvest the nerve graft without limitation since it's located in the middle, but you harvest it as a free nerve graft, practically like a free flap. And because you can harvest the dorsal cutaneous branch along with the distal ulnar nerve, you can hook up to 2 targets. So this is the way that we like to use it. If we have a very healthy proximal ruptured stump, a spinal nerve, and it's been confirmed by MRI and our own exploration, we prefer to use the vascularized ulnar nerve graft to hook up to the median and the muscocutaneous nerve. And this is what we would say a good ideal nerve stump that you would see. And I know, Dr. Brown, you've been to Taiwan and you must have seen Dr. Tron's dissections, in which he does a very extensive dissection to try and dig out that stump. And then, when you have that stump and you try to hook up, no, this is the harvested nerve graft, but that's not the final length. I would trim it much more. And then you hook up the proximal end to the C5, and then the vessels to the transverse cervical vessels, and then the distal stump to your recipient nerves. And then here's a example of a case where it's a C5 rupture, C6 to T1 avulsion. There's the shoulder and the elbow flexion you can see, but you can also see here that the patient has quite sufficient finger flexion strength. Again, with a strong elbow flexion, seeing with this vascularized ulnar nerve graft, the patient's actually able to freely supinate. Of course, there's a bit of help with that gravity, but at the same time, the pronation, also comes from that median nerve. And then in another case, this is actually my own case. Again, you see that strong forearm, see that strong elbow flexion, but it's also supinated. And this is another patient, again, with the ipsilateral C5 to the two targets. And you can see that very freely movable. There is a lack of finger extension, I have to say. So the patient does have to push his fingers out to try and get some kind of grip. But the finger movement that you can see here, you see that finger thumb movement that you don't see with functioning free muscles, say with the Doi technique. And you see that grip, the control with the ball. Again, he does not have any wrist or finger extension. You need an orthodesis of the wrist, but you see that freely movable and actually a firm grip of a ball. And for these patients, they're able to hold a water bottle with sufficient power to assist their uninjured limb. It's never going to become the dominant limb again, but whatever they can do to help their other hand is already so much help for their quality of life. In terms of daily activities, being able to eat an ice cream, we all know how important that is. To be able to play with your phone, to be able to play a guitar. I shut off the music because it was too loud. To even be able to ride a bike with that sufficient grip. Yeah, I wouldn't advise this for all our patients, but that's definitely something that I think this patient really pushed himself to the extent. Next, I'm going to talk about panbrachial plexus palsy, total root avulsion, and I'm going to get into contralateral C7. But before I get into that, if you have any questions, please just stop me anytime. Or Dr. Brown, if you want to comment.
Absolutely. No, that's very exciting, this idea that you could use just a C5 root and get that much function out of it. So you've got my interest peaked here. When we transfer our free functional muscle, there's always that concern that you're not going to have good blood flow down the line. We, monitor it with a skin paddle and so forth. Do you have a greater level of confidence that your vascular repairs are going to take and survive in this setting? Or
yeah, actually, I believe so. It's definitely much easier to inset a vascularized nerve graft than a functioning free muscle. I think functioning free muscle is definitely limited by that pedicle length. But with the vascularized ulnar nerve graft, your vessels and your nerve, they just have to be linked together for a sufficient length. But you can definitely dissect a little bit, get that nerve and artery and vein a little bit further off, which will give you more length of the pedicle. So, but I really believe in using the ulnar artery and vein. I think it's a much better choice than the superior ulnar collaterals. Okay. All the papers that, the JBJS paper from Mayo, some of the papers from Thailand have all used the pedicle. And I think they're trying to mimic the way that Dr. Gu had recommended in a two-stage manner. But I just think that with the free vascularized ulnar nerve graft, and this is something that actually Dr. Tertzes does too, yeah. We've seen better outcomes. Yeah.
And
but that's not, oh, sorry, please go.
Did you say you wait 6 months to do this, or how long do you usually wait?
Within 6 months, I would, yeah. I think the earlier the better. I wouldn't wait that long. I think most of these panplexes don't really end up as an incomplete. The only time I would wait is that if I see a flicker of any type of median or ulnar, the T1 is coming, which again, it's hard. If you have a Horner syndrome, it practically takes it out. But if there is that hint of it, then maybe our strategy completely changes because we don't use that vascularized ulnar nerve graft anymore. So yeah, then we would do the functioning free muscle.
And then one more, how reliable is this that you're going to get elbow flexion and some finger flexion with this strategy? If you have
yeah, we're trying to get this published because most people don't agree with this philosophy. I would say elbow flexion is to be a conservative, I would say 80 to 90%, far more reliable than the intercostal. I don't really like intercostal, and I'm speaking from a country that has thinner BMI. Yeah, so yeah, but I've always felt that the intercostal nerve has been a bit, probably takes a bit longer. Yeah.
Well, you've definitely got my attention. On that case, for when I have only a C5 or shooting for some shoulder, and yes, I'm always going for intercostals for biceps. So if you can reliably get biceps for this, that's an exciting contribution for sure.
It doesn't mean that the intercostal is not used. You can use it as a backup. If you decide to, the spinal accessory and your intercostal or the two donors that you have in mind, that you can either use one for elbow extension and then the other one save it as a backup for a free functioning muscle. So we use it, and I prefer the intercostal nerve to be the backup because it's usually, the thoracodorsal area is the part that you don't dissect as much. Yeah, and when you're doing the vascularized nerve graft, everything is more infraclavicular. Yeah, so that's the preference. All right, so should I just move on, or is that okay?
Right, Jorge, I'm sure Jorge has a question for us.
Dr. Clifton, yeah. I can't hear anything.
Jorge, you're muted. You're muted, Jorge.
Yes, okay.
There you are.
Great. So the whole group is enjoying your lecture, sir. It's very thoughtful, and definitely it's a complete different results with Dr. Bertelli paper. And I think we're going to consider this for our next patients. And so the time limit is 6 months.
With these Plexus, it's not often that you get them at 6 months, and everyone knows that it's just that the Plexus, a lot of them have really bad injuries. So when they're referred to you, it's 6 to 8 months. And but if you can get them at 6 months, then if you pass 6 months, you can still do them. But I would say the outcome takes a bit longer, not the usual outcome that it would come back. But you have to be really patient. And this is something that I will talk about later with the vascularized ulnar nerve graft. Things don't come working in that first year. And I learned this the hard way through my own patients and also with working with David. The things don't get really activated until the second year. Yeah.
Okay. Okay. You mentioned that around 80 to 90% of elbow flexion you get with this procedure. How much percent you get at those cases? I will consider those are your best cases of finger flexions. That's correct?
Could you say that again? Sorry,
I guess that the cases you show are the best cases you have for finger flexions.
Yes, of course.
Yes. What is the percentage of finger flexion that you get, and how many patients? I mean.
We have a study that we're trying to publish. Again, the results that we have from maybe about 60 to 70 patients with a finger flexion, I would say it's a little bit more unpredictable because we collapse to two targets. Sometimes there is a bit dispersion of the axons. So to get back to your question, I really need to go back to the data for that. But I would say 50 to 60, 50. But that, you don't always have that grip. Sometimes it's just kind of like this, and you need to do additional procedures to help with that. But at least they get sensation. I think that's the thing that we like doing this, is that sensation does recovery. But if you have a weak finger flexion that don't come about with doing this, you can use the functioning free muscle and coapt it to the distal branch of the median nerve to get more of that forearm flexion, to get more of that finger flexion. But in terms of percentage, and I think finger is the hard part. If I tell you that 50% achieve M3, you'll still be very perplexed and be like, M3, is that a good thing or a bad thing? So I'll be honest to tell you that not all of them have meaningful finger flexion. They have flickers of it, some better, some don't. But then we have another thing that I always want to emphasize is backup. And we use that function, we use the functioning free muscle.
Can I ask you about that one now? You would be, if it failed to provide finger flexion, you'd be confident enough to run a free functional muscle off of that same nerve, assuming that there are enough axons in it? I'd probably go to intercostals myself if I had failed on that one.
Yeah, well, I think having sensation in that hand is a sign that it did reach. You can do Tinel sign. We don't do any NCV or EMG to help, but I think that's where we use. But if there's a completely lack of anything going into that hand or finger, you're right. You shouldn't trust that.
Okay. And if you do have sensation in the hand, what branch of the median nerve are you going to use for that source for the free functional muscle? Are you going to go?
You could use the pronator teres. You could use the or any of the motor branches actually.
Pick any of them, huh?
Yeah. Okay. Maybe you can even the AION. Like I think David prefers to use AION, but honestly, we take any of those nerve motor branches. Pronator teres is probably the most reliable because it's the most proximal.
Yeah.
But any of that distal branches, the FDS, the PL, the FCR, you can stick that all into the muscle by doing like a nerve to muscle neurotization.
Okay.
Yeah.
Very interesting. All right, I'll let you continue the talk. This is great.
Yeah, thanks. All right. So in the total revulsion, this is another big topic, and I think Dr. Bhatia is here, is definitely can provide some of his insight into this. So for these cases, again, Plexus, nothing in the entire limb, but then you do the MRI and it tells you that when it says VP4, it means that the ventral root has only one rootlet that's still there, but the dorsal looks to be okay, but actually there's no ventral rootlet. So practically it's still a useless nerve, useless stump. So for these cases, we do the contralateral C7, and that is actually primarily used for the hand only. We don't use it for hand and elbow that much because with that longer distance, definitely there's still, trying to reach two targets, maybe a bit more burdensome. So we do this. We don't do it the Dr. Wang's way, where we do the direct coaptation to the lower trunk. We have tried that, but we haven't really gotten good success, especially with the tension part. But I believe it's doable. I think it's just probably me. I need to learn more from Dr. Bhatia and Dr. Wang, but we prefer to use the vascularized ulnar nerve graft with no tension at all. We hook it up to the C7, the entire root, the entire stump, and then we use a subcutaneous tunnel rather than a retroesophageal tunnel. And then you can hook up from the contralateral C7. We mainly use it for the median nerve. You use the other side, the contralateral transverse cervical artery to hook up to the ulnar artery, the distal ulnar artery, a bit of a retrograde, and then but the proximal ulnar vein you hook up to the EJV, and then for the muscle cutaneous we use the intercostals. When everyone talks about the contralateral C7, they always talk about the donor site morbidity. They always talk about the functional outcome. Is it worth it? I'm not here to convince you otherwise. I'm here just to show you our results, what we believe in it. But I do want to say that for total root avulsion, anything you do is going to try and be able to help them, anything you do. So this is our efforts. And the paper that came from Michigan, Dr. Kevin Chung, when he published in 2015, I think he had a part 1, part 2, and he looked at the donor site morbidity. And the sensory abnormality did list here. And, from this table, it looks like it's actually very, it looks like it's pain. It looks like it's something that's not good, disadvantaged for the patient. They also mentioned that the triceps was most often cited as the muscle that's affected. But for us, we used the anterior and posterior division, both of that contralateral C7. I would say the finger numbness, it's not temporary, it's definitely permanent, but you have to look at it as an alarm. The whole point of doing this sensation recovery, or trying to restore sensation in the injured hand, is so that these patients don't get injured when they get burnt, or when they get stabbed, when they get bitten. And so that numbness, in which it does look like it's a morbidity, is not really, it's to that alarm. It's that kind of like a fire alarm. And the patient will always mention that they feel something in that contralateral side. They can still tell if someone touches their injured side, or they touch the normal side of the numbness. And I would say most of the patients aren't too disturbed by this, as long as you explain it to them preoperatively. This is Professor Gu.
Tell me about your numbness there, because so they notice a difference in the sensation, but they're not anesthetic.
They're not anesthetic.
Right.
It's not completely nothing. Yeah.
Right. It
It's
just feels different than the other fingers, but they're still perceiving. Yeah.
Yeah. And so this is actually one of the slides that Dr. Gu, when he presented, and this is actually in Jinan when I met Dr. Bhatia, and when Dr. Gu was talking about why he uses the contralateral C7, and mainly it's the motor comes from the posterior division. But for us, in terms of the motor, in terms of the motor recovery, this is about 1 month after. This is actually just when the patient was removing his suture. You can see in the contralateral side, the patient is still able to have adequate chill rate reduction, and also the triceps function. And again, you can see that the patients are able to have some weight, being able to have that elbow extension against gravity, and even against having weight on it. So David has actually presented on multiple studies on this, even looking at the donor side morbidity of the contralateral C7. Basically in the 28 patients, no, in the 230 plus patients that we have done with the contralateral C7, there is no permanent loss of that shoulder, elbow, or finger flexion or extension. David does mention in that paper that he did, where when you transect the C7, there may be an absence of a triceps reflex. I'm not exactly sure what that is. Definitely, Dr. Brown, you would know this much better than I do. But in terms of that voluntary triceps movement, I think it's still more than enough. Yeah. But if the intraoperative C7 stimulation does result in very obvious wrist and finger extension, we have noted that there is a weakness, transient weakness of that triceps and EDC, but again, it does improve over time. And with Dr. Shin's paper in the hemicollateral C7 transfer that they've done, they have not gotten any good results. And but I've looked into that. Again, it's a pedicle vascularized ulnar nerve graft. But I think one of their arguments, I've talked to Dr. Shin about this, is that he just feels that using the contralateral C7, it's not very easy for these patients to induce these movements. Do patients gradually be able to control these limbs without the contralateral side? In my experience, in my own patients, limited patients, I don't see that. I still see a reliance on the healthy side, the adduction of the shoulder. Again, this is from Thailand, in which again they did mention about 29% able to reach M3 or M4, for experience M2 recovery wrist and finger. And again, they did mention that it's not very favorable in their opinion. And again, they used the hemicontralateral pedicle vascularized ulnar nerve graft. In our cases, this is a contralateral C7. This is my own case, in which this is what we did. You could see that with the contralateral C7 to the median nerve, you do see that finger flexion. What's even more interesting, actually, is that if you ask the patient to use that median nerve, there's a very strong pronation noted. I'm sorry, I'll go back to here again. This pronation is actually a bit annoying for these patients. So I would recommend arthrodesis. This is before he did arthrodesis. but that finger flexion is not as meaningful. This is the same patient, but again, it's more FDS than FDP. So I would definitely say that there is finger flexion, but just not as meaningful. I think the longer the time of the denervation process, the harder it is for you to achieve that distal bit.
Have you?
Johnny, can I interrupt, please?
Yeah, sure.
I'm sorry, I'm interrupting, but I'm running out of battery on my phone. So
Okay.
I wanted to put in a word on this. See, a lot of these publications on the contralateral C7 talk about the recipient function and try to individualize them. What we don't understand really is that this function is being activated by the opposite upper limb. All right. So it is always a mass action. There is never individual FDS and FDP action. The patient cannot differentiate in the target muscle that is achieved. Secondly, since it is all a mass action, it is not useful to transfer a part of it to try and get something else. If you get what I mean.
Yeah.
The recipient action, even if it looks strong, it is still being activated by the brain's order going to the opposite upper limb and then working its way to the recipient upper limb. So which is why we were rather forceful about eliminating two sites of repair, because each site of repair leads to axonal loss of around 30% and leads to a longer delay. Therefore, you get fewer axons innervating the target muscles. When we use the vascularized ulnar nerve graft, you are eliminating the ulnar nerve territory altogether distal to the elbow. So then automatically it means only the median innervated forearm muscles. And that with two suture lines from the vascularized ulnar nerve graft leads to a real dilution of the target function. So, I mean, I really would like to discuss at this level that are we justified in sacrificing the ulnar nerve territory at all?
Well, these were avulsed roots, so I don't think you've lost anything. But so
no. Please, Justin, you're not getting what I meant. When you're taking a vascularized ulnar nerve graft, you have divided it distally and turned it proximally.
Yeah.
Therefore, whatever comes along the graft will only go to the median nerve. It will not go to the ulnar nerve.
Correct.
So the recipient muscles will only be FDS, all four slips, FCR, pronator teres, and the FDP of the index and middle at a
FPL.
at a clutch. And the FPL. All right. So we have eliminated the ulnar nerve territory in terms of the flexor carpi ulnaris and the FDP of the middle ring and little fingers. Yeah. As potential target muscles. And
I have to say, I don't consider that a significant loss. You know, in the patients only go after AIN, and really the entire hand closes adequately. If you got FCR, are you really disappointed that you lost FCU? I'm not sure you would be.
No, but then what I really meant was that addition of a suture line is you have brought down the axonal count coming from the opposite C7 by 60%, 30% loss at each suture line, and the axons will arrive later and will innervate fewer muscles.
We'll have to have a side-by-side competition of the retropharyngeal direct repair to the lower trunk and the vascularized ulnar nerve graft to the median nerve. See what we get. But, it looks like it's working. And then the other option you have, Johnny, is if you're getting FCR, if you're getting pronator teres, if you just take those distal tendons and put them into whichever fingers are the weakest, you're going to augment your grasp. And it's going to be a mass movement anyhow.
It's a mass movement. It's a co-contraction, the entire thing. I think that's what Dr. Bhatia is saying. Definitely, I agree. It's never going to be individualized control.
Yeah.
But I still believe that if you trying to get that, I think the focus is still trying to get that grip. Is still trying to get that again at the same time with the sensation. So I do believe like when you're doing an orthodesis, any of these additional, you have to do orthodesis. It's pretty much mandatory. A flail wrist is not going to help anything. And you can use all that flexors that you have and the pronators and you hook it up to any of the FDPs and try to get stung. But there's no way around that. The thumb is still it's still like this. It's not going to have that part focus. So you still need the orthodesis. So I do believe it. But back to my argument about when we're talking about do you hook up to the median nerve or do you hook up to the lower trunk? I've seen the results with Dr. Wang, with Dr. Bhatia. And also I do believe there's one less suture, but because it's more proximal, I still believe it's more dispersed as compared to the median nerve because we coapt actually both contributions of the median nerve from the lateral cord and also from the medial cord. So where our focus is actually just on that target of the median nerve rather than the dispersion, which is more proximal with the lower trunk. But I know you're also trying to get wrist extension because I've heard that from Dr. Wang's talk. Is that right?
They were going for finger extension using the phrenic to the posterior division of the lower trunk, but I think that was a less than 30% success rate on that.
Yeah,
speak to that better.
We've tried to do that primary coaptation, and and I did, and that was with David, and he's had trouble trying to reach that without a nerve graft. And
The phrenic now, can I interrupt? I'm sorry.
Yeah. Yes, please. Yes.
I agree when you say that the quality of the stump of the posterior division of the lower trunk in an avulsed lower trunk is not the best, and therefore when we try to get it back into the neck for direct approximation of the phrenic nerve, that becomes an issue. The way out here is always to divide the thoracodorsal nerve and the axillary nerve.
So you can pull up proximally.
So you have
so that the posterior cord moves further proximally, and therefore the stump of the PDLT can be trimmed with liberty. Right now we trim it less, so because otherwise it will not be visible in the neck, and you can't do a repair.
Yeah.
So the way out is to do the full dissection, deliver the lower trunk below the clavicle, split the PDLT all the way back up to the C8, then put it back into the neck, and then trim it. And if then it is tending to hide behind the clavicle, one can divide the thoracodorsal nerve and the axillary nerve so that the posterior cord can be pulled up further.
That is very challenging, and that's amazing, Dr. Bhatia. I would have trouble doing that. That's not an easy procedure.
No, honestly, it's a piece of cake. I used to get frightened when I saw Wong doing it, but I've done more than 100 of these.
Yeah, you have definitely the most cases of this. So again, I think just back to this use of the contralateral C7 and the meat. I think the main focus is just trying to restore something in the hand and not give it up. I think that's something that, being to multiple meetings, I've always had this kind of insight where people give up on the hand. Yeah. And I don't think it should. Yeah.
And can I give one more comment on the hand, because this is something we deal with all the time in the tetraplegia population, is you've got adequate finger flexion there, but then you have to get down to how do you make that more functional. In that thumb IP, if you fuse that IP joint, get that thumb into the straight position, and then pull down the MCP joint of the index finger so that thumb can land on the side of the index finger for a pinch, you take the power that you do have and you put it in the places that matter the most. Yeah. So the wrist fusion, yes, probably thumb CMC, and then probably thumb IP. So the only translation of the thumb is happening across the MCP joint. So you can land that on the side of the index finger.
Yeah.
But I think you've got a lot going on down there, and I think that is successful.
Yeah, that did came. It was interesting because I did this case before I went to St. Louis, and then after I came back, and my colleague Tommy Chang, looked after the patient. Somehow he had a really good median nerve, but I tried to convince him for arthrodesis, and I think kind of the patient kind of lost faith in me because I left him for St. Louis. So anyhow, Dr. Bhatia, is it okay if I move on to my
Please.
presentation? Yeah, thanks.
I'm sorry I interrupted. Sorry.
No. The discussion is actually more important than anything. Again, another case, total root avulsion. This is the shoulder that comes from the phrenic nerve, the suprascapular. This is the elbow and finger flexion. The elbow is coming from the intercostal nerve. And then the finger flexion, again, it comes from that contralateral C7, and you could see that grip. I think this patient has less of that kind of a claw finger and more of that grip that he's able to use. And again, this is fused here, and this is Dr. Tron's patient. But again, I would have to say that the patient is reliant on that contralateral side. This is a case that my colleague Tommy did, and he actually hooked up the contralateral C7 to 2 targets. When we hook it up to 2 targets, the elbow flexion definitely is quite strong, but the finger flexion does kind of becomes a bit weaker. And so definitely this is one of these cases where you do need to do something else in addition to get more of that finger flexion, maybe even to correct this claw hand. This is a study that actually we worked in. I'm sure Dr. Brown and everyone, and you guys have some experiences with this. This is it's called Graft, but it's more like a body motion sensor. You can use it to detect the time per day that limb is moving, and you wear it on the wrist, and you can also measure the magnitude. I don't know the science behind this. This is a study that we worked with Michigan, mainly with Lydia Yang and Susan Brown, and we looked at 29 Pamplex patients. And out of these cases, 38% used the ipsilateral C5, 55% used the contralateral C7. I'm not going to get into this because even though MRC does state that there's good movement, it's not really reflective of actually does the patient use this or not, use these limbs or not. Interestingly, the average out of this whole group in the terms of the VT, the time that you would use was 0.54, which means that 55% used their limb more than 55% used their limb more than 50% of the time of their contralateral side. The magnitude, of course, is weaker and ranges from 0.16 to 0.71. And I think the contralateral C7 definitely has a lower magnitude. But there was no significant correlation between the VT, which I'm actually more interested with any of these outcome measures that we use, even the type of surgical strategies, the MRC. But it was very interesting to see that the patients with contralateral C7 performed similarly without any significant difference to the cases with ipsilateral C5, even though visually, when we see these patients, we see a kind of a dramatic difference in, the contralateral C7 seems to be harder to use, but these patients have actually gradually evolved to really learn how to use it and to help them in their daily activities. This is the instances where if you have that lack of median nerve coming in, but you do have sometimes sensation, but it's just weaker. You can use the contralateral, you can use the functioning free muscle, the gracilis with the skin paddle, and you can hook up the pronator teres branches or the AION, and then put all these motor branches all inside this muscle to restore that finger flexion. And this is a case where we have, this patient is quite aggressive in doing rehab, and this is actually post operation 7 years. You can see the laxity in the finger, but also some sort of finger flexion that is strong enough to help him with his activities. And you can see that contralateral C7, that functioning muscle contracting. So in essence, back to kind of the strategy for Plexus, I think it's very important, as always, history should never be neglected. You have to know, especially time since injury, never neglect that. We always had imaging. We've gradually evolved our practice to be very reliant on MRI, especially for the younger surgeons, me and Tommy. But we also, at the same time, we always explore the plexus. It's even if the MRI tells you that the root is not good and you see something during exploration, you still use it. Don't leave it out. We don't do any intraoperative SSEP, all that, but we still use the MRI to help us kind of to determine the level 1, the near the spinal cord, what's the quality of the rootlets. We also use the NCV and EMG, and everything has to be with the planning. The plan is not decided before the surgery. The plan should be decided intraoperatively to decide what donor nerve you have, and then you perform the surgery. You can't do functioning free muscle at the same time. You know, the concept that I think Alex Shin mentioned about using the intercostal to muscle cutaneous and the intercostal to functioning muscle for 2 functions. I think that's a viable thing that maybe I would like to try someday. But for us, we still prefer to use the functioning free muscle as a backup nerve. Why? Because you need to give time to wait it out of your results. And this is something I want to say. This is a case where we did kind of the C-loop method, the vascularized nerve graft, and we used the C4 and the C5. And the C5 is actually hooked up to 2 targets. You can see at 8 months, the patient doesn't really have some flickers of that finger flexion, not too much. But you know, for us neurosurgeons, every time we see a contraction, we're like super excited, but our patients usually don't really understand why. But good things take time. You see this at 8 months. If you see this at, you know, if you don't see this even at 1 year, I would tell you to just wait a bit. You know, if you do a nerve graft, believe in it. Don't give up too much. If it fails, of course, then it's a failure, but you have that backup component. At 1 year, the same patient, you see that much better finger flexion from that median nerve. Again, there's this co-contraction of the biceps, but you see progress. You see progress at both sides. So, I'm sorry. So with that, that's actually the final bit, the last slide. So I just wanted to tell people that if you do want to use the vascularized ulnar graft, you can consider it. Definitely, you need patience, you need time for it. It doesn't come easily, but it's something that you can consider. I go by microneurosurgeon in IG. So if you have any, please feel free to message me if you have any questions. I do want to go into one last thing. David and Tommy specifically told me to do this. We have this instructional course that we did in 2009 and 2017, where we we invited international lecturers and to come and do live surgeries. And this is where preoperatively, all the patients actually are done, are shown how they do the physical examination by the operating surgeon himself or herself. And then afterwards, the patient goes into the surgery room. This is Dr. Oberlin, again, showing this compatibility. And you can ask questions during this live lecture, during the live surgery, and then see the compatibility between the PE and the actual surgery. And then afterwards, have a very intensive Q&A. There's Dr. Hattori, this is Dr. Wang and Dr. Oberlin and Dr. Tu. And so we're actually holding another course in 2023. The date is not particularly set, but it's going to be in November 13. We're also doing a facial paralysis reconstruction instructional course too. So if you have any questions, feel free to contact me. So thank you so much.
Thank you very much. That sounds like an excellent conference. I love that sort of interchange.
Thank you, Dr. Brown.
We'll have to look into that. You know,
Yeah.
just as you see, we have a lot of questions we like to do back and forth here. Hey, one other for you. I've been doing a lot of, 6 intercostals to the lower trunk or to the medial cord or to the median nerve. And I have a couple of patients didn't really get much motor, but got all kinds of sensation in their hand, all radiating to the chest. At what point do you say the motor hasn't come, I'm going to drop that gracilis in there and run it off that nerve? Because I have a couple of good candidates that I'm thinking about right now who have a lot of good sensation. They've got a lot of intercostals in there. What would you give up at year 3?
Intercostals, right?
I use intercostals as the source on this, but I use 6 of them. I use a lot of intercostals.
So if you're going to do a functioning muscle, what's the donor nerve? You're still going to use the intercostals?
So now it's either the ulnar or the median. So they went to the medial cord of the brachial plexus.
And so you would use
sensation
just more distally. You use the median and the ulnar more distally, you mean? To hook up to that muscle, you mean?
So now we could do that. That's right. So we could use the ulnar FCU and FTP branches. We could use the Probably that would be the best because they'd be the most proximal branches coming off, and the ulnar distribution is where most of the sensation is in these folks.
I would wait at least 2 years after the surgery.
Yeah.
Yeah, but when you said the third year, I would say so. There's been instances where I really questioned myself, and David was always telling me to wait, and I could see why. So
Yeah.
yeah, but during that time, I think it's also when you communicate with the patient, letting them know that that's something in your head. And
Yeah, no,
I
we
guess-
were already discussing other options for free functional muscle, but I never considered going off of that. And if you guys
Yeah.
have a series where you're having success with that, that's an interesting option to consider. Yes, Jorge.
Okay. Oh, I really like the 4-year concept for looking at the end results. Like 4 years, I think it's a great time. I really enjoy your lecture. We're like 20 surgeons here listening to your lecture, Dr. Lu. We're very excited. And I just want to announce that in 2023, in March, we're also going to have a course here in Mexico. It's a 3-day course about the hand function through the eyes of nerve injury. So it's going to be a great place for you and Dr. Anil Bhatia. Have a great round. It will be great to see you here.
Yes,
Get
I'd
out.
love to.
In March 2023, before your meeting.
I would love to. I think I'm already actually coming to I do want to go to Mexico for the WSRM that Eric Santa Maria is holding. I think in
Okay.
September, but
Okay.
I mean 2023 is the actual.
Okay, that's great because I'm in charge of the brachial plexus section. So definitely I will have you in Cancun.
Thank you. Yes, we can have a drink. Please take me around.
Okay, definitely. And
Yeah.
also, just you're always should consider to coming here with your family to Cancun in June 1st to the 4th.
Yes,
Beautiful.
June. Yes.
That sounds great. Thank you all very much, Johnny. I love that talk. That was excellent. We have patients waiting for us in clinic, so I'm gonna have to run, but that was
Yes,
perfect.
yes. Dr. Brown, we have that. I just wanted to remind for everyone that you're okay to talk on the December 19th, the International Microsurgery webinar. That yeah.
Yes.
Yeah.
Want to make
Yeah.
sure it's on my schedule. We
Yes,
definitely
yes.
agreed by email. I'll confirm in 10 minutes.
Yeah. I've already had Dr. Fox, Ida Fox. She's gonna attend, and I think
Okay.
Lorna and
Perfect.
Samsak, Dr. Lichevevon, I think he wants to attend too. So we're gonna have a good welcome for you. So
Perfect.
looking forward to see you that day.
I
Yeah.
look forward to it as well. Thank you so much.
Thank you so much. Thank you, everyone. Thanks
Have
so
a great
much.
day. Take care.